Good afternoon. Good afternoon and welcome to the Rocky Mountain MS Center's special webinar series on COVID-19. Today, January 7th, we will be giving an update on COVID-19 vaccines and MS. This presentation features Dr. Enrique Alvarez. Dr. Alvarez is the clinic director at the Rocky Mountain MS Center at the University of Colorado. He is a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013. This webinar features a lot of important information. Most of it is data heavy, and we will go for at least the full hour, if not longer. If you missed something on a slide, want to hear something again, or have to leave early, we will be archiving this webinar on our website, www.mscenter.org, so you can replay it at any time. We'll reserve some time at the end to answer questions from the audience. You can submit your questions at any time by typing them into the question window on your screen. We will answer as many questions as time allows. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. With that, we'll turn it over to Dr. Alvarez.
Hi, guys. Thanks for the invitation again for giving a little bit of an update. I think we're getting to the point where we're starting to get a lot more questions than we have answers for. And so I will apologize that I think there's going to be a lot more information to come than what we currently have. With that, we'll go ahead and get started. For people who have been watching these, I'm going to go through just a little bit of some of the similar data that I have in the past. I'll go with them a little bit faster than I normally do as far as some of the numbers, but I'll try and put some twists and then really kind of concentrate on vaccine use and kind of what we know and unfortunately what we don't know. So we'll talk a little bit about numbers. We'll talk about risk factors, MS, the drugs, comorbidities, kind of what we know as far as this stuff goes. And then we'll get into some of the vaccination information. The reason for bringing up a lot about the risk factors is because when questions around, does MS increase my risk of bad COVID? What about this drug? We have to put that in context with everything else for that person. And that's the part that is really important to kind of compare that so that we have a better understanding of that. So with that, let's go ahead and get started to see where we're at. So if we look at the global numbers of patients in the world right now, we can see that we are a little bit in a plateau. Numbers are starting to kind of level off a little bit, still some ups and downs, maybe a little bit of a slight upward trend a little bit. We are up to 1.8 million deaths, so we've not done great, and almost still about a 15,000 deaths per day in the world, which is an impressive number when we think about it. In the state of Colorado right now, for example, the number one cause of death is unfortunately COVID. So if we have to understand as well the differences between countries, we can see that we're sort of in the kind of in the middle of our third peak, that this has been by far our largest peak as far as MS goes. If we look at other countries, some of them are on their fourth peak, some of them are on their second peak, and this peak is sometimes bigger or about the same as the first one. Sometimes it's much larger. There's been a lot of concerns around the UK, and I bring this up to highlight a little bit because there's going to be probably some questions around the new strain of the COVID virus. As we understand it right now for the new strain is that it is more easily passed from one person to the other. I've heard numbers of anywhere from 60 or 70% higher, easier chance of passing it on. It appears to be that that's because there's just more virus present in saliva, and when we speak, it's just much more likely to kind of get passed on to other people. And And the UK really is kind of where that new strain started, or at least was identified. And so this peak has been attributed a lot to that new strain. We also have to understand a little bit about that deaths are just simply what we understand and can count. This is kind of showing that throughout these peaks, we kind of on average have a sense as to how many deaths there are in any given day. And so we can see that during these spikes that the number of actual deaths was much higher than what this expected number was. And so that these cases of deaths may not necessarily be related directly to the virus, but they could be people who maybe had a heart attack and were too scared to come into the hospital or things like that. And so people who maybe never got tested and were suspected and things like that. So that there is a true number of kind of increase unexpected deaths that are not accounted for with COVID, but that unfortunately we're still seeing this extra increased risk of death happening. And you can see again that this is very variable by country. And the concerning part about it is that, at the beginning, a lot of this was limited by testing and not having information. But we're starting to kind of see that in a lot of countries that that separation was starting to kind of happen. This hasn't been updated much recently. So it was last updated November 27th. And this is from an article at the New York Times. So not accounting sort of the latest, but we could see that there's, some area for concern in some of this. So let's look at Colorado numbers, and in monitoring some of these prediction models, we can see the actual numbers of cases kind of coming through. So our second peak did not match the second peak in the US. We had a fairly big initial peak that started pretty early. Colorado got hit early, and then we did really pretty well over the summer. Our numbers started to kind of go up a little bit earlier than some of the other states around us. We kind of controlled things. And as we get into the winter months, there's kind of an expected kind of bump up in cases. We're not seeing as much. This is starting to kind of get into the prediction area over the last 2 weeks. So this is kind of our normal cutoff. These numbers, just to provide some perspective, if we looked at this model about a month ago, this line, this dash upper line, would kind of go all the way up and above where this line up here describes all the beds available. I mean, we were expected to get more cases than what we had beds. We are still expected to get more cases in the ICU than we have ICU beds. The blue dash line is the number of intubated patients. And again, this number was way much higher, and it's finally starting to kind of get to a lower level. And this reflects, I think, the strong efforts that we've had in this state about wearing masks, social distancing, kind of shutting down businesses, for good or for bad, but at least as far as number of cases for COVID, they've really had an impact on these projections. When we look at these projections, it is important that they do take into account a lot of different things. So you can see sort of what the expected numbers are here. If we start to open up things and kind of ease up our restrictions, we can see that the number of cases would be expected to kind of continue. We can see that that curve can come down a little bit faster if we can really roll out the vaccines faster. If we put in like universal masks, Colorado is pretty good, around 80% use of masks. But if we get that up to 90%, you could see that the number of daily deaths would be dramatically decreased even that much more. So this is through a website called, an institute called IHME, and you can go through these websites and kind of be able to monitor these things and continue to follow them. This site on Thursdays has been putting out a report on Colorado that has a ton of information. It is a huge, massive document about, per county levels of everything you would ever want to know. And it talks about the reproductive number for COVID. The reproductive number is the number that we look at to see if the numbers are going up or going to go down. One is meaning that each person who gets COVID transmits it to one other person. If it's higher than that, the numbers are going to go up because more people are getting it for each person. If you get it below 1, then numbers would be expected to go down. And we've been hovering around 1 for most of the month of December. So that's kind of where we're at from a numbers perspective. So let's look at some of the risk factors for bad outcomes with COVID. And then we have to kind of be able to start looking at MS disease modifying therapies. For people that have been following this series, I'll present some of the same data that we have, and I'll go through it a little bit faster, but putting it in context around who and when people should be vaccinated. So if we look at the numbers for Colorado, this is the number of cases, and we can see that the number of cases, once we start looking at it, are really kind of going through a big wave, and we can kind of split it out by age, and we can see that really it's the younger population that has had sort of an excess number of cases. Older folks have actually been very good about protecting themselves from getting COVID. Unfortunately, when we look at the number of deaths, we can see that it looks very different. And we can see that when an 80-year-old plus person gets COVID, over half of them die. This looks very different in number of proportions compared to the data we just saw. If you're in your 70s or 70 to 79, we can see it's almost a quarter of patients dying. But as you start to kind of get into these age groups, right? So the 20s, the 30s, where we see a lot of cases, very few of these people actually die from COVID. And I think this has led to a little bit of a nonchalant attitude and a little bit of why in the last big spike, we have been saying, oh, the virus appears to be less lethal. And some of that has been because nursing homes and some of the high-risk populations really started to be careful. And some of these groups, these younger groups, started to kind of be a little bit more nonchalant about it and taking a little bit more risks and those kinds of things, because they would say, hey, my chances of dying are less than 1%. Let me just get it over with and kind of move on, that kind of stuff. So age has a huge effect. And we can see when we start talking about the guidelines, why the emphasis is being placed on patients who are over the age of 70, because you can see that the bulk of the deaths happening are in these patients. What are some of the other risk factors? Well, men, being a man is a worse outcome for having severe COVID. Certain ethnic groups have been associated with having a higher risk. When I did this last time, African Americans and Hispanics had higher risks than what we were describing. We can see that actually these risks right now don't appear to be any worse than they were before. The Hispanics was at 23%. It is down to 20% of the people who are getting it. So some of the ethnic things seems to be dying down a little bit. So let's look at some of the comorbidities. Many of you have seen some of these before. Understanding that heart disease, cardiovascular disease, and by heart disease, right, we can talk about many different spectrums of things. So, hypertension, is it well controlled? Is it not well controlled? Diabetes, is it well controlled, not controlled? So these are spectrums. Cardiovascular disease is getting into people who have actually had heart attacks, for example, who have heart failure. When we look at this other study separated out a little bit more detail, and we can see that ischemic heart disease is one of the biggest comorbidities risk factors. And there's some discussion that because the virus seems to attack the receptors that are present in the heart cells, that this is particularly the reason for some of this stuff. Atrial fibrillation is a heart condition, stroke, arterial hypertension, diabetes kind of starting to drop off. And then it's not the matter of whether you have any one or of these, but also if you start to combine them. So if you start to have more pathologies, people tend to do not as well. If you don't have any of them, the chances are you will do very well. 0.8% of people had no comorbidities of people who died. But those people who died tended to have 3 or more of these. So this is an important factor when things are starting to get stratified as to who should get vaccinated. So let's look at the question about whether MS increases the risk of bad outcomes. And the answer for that, the short answer for that is no. This was one of the original kind of larger papers. There's some series as well from New York hospitals that are really good. This is from a large registry that occurred in France. And we can see that age for every 10 years increases the odds by 2.5-fold, or if you want to think about it, by 150% for every 10 years. So you can see that is a big risk factor. Men have almost in this case, over a 2-fold increased risk over women of having bad outcomes of COVID. Looking at comorbidities and which ones, cardiac versus pulmonary, a little bit better. Diabetes in this case was worse. We have to understand in different populations, diabetes might affect that differently. Smoking in this case was, the number would say it's protective, but this line crosses this dash line, meaning statistically, it's hard. We would say that there's no difference. Obesity having a 3-fold increase. Progressive in these patients had a nearly 8-fold increase. So this was kind of one of those things that made it particularly bad, more than any other comorbidity. But why would progressive disease make it that bad? And probably because progressive patients tend to be more disabled. So if we look at the disability status scale, expanded disability status scale, the EDSS scale, if the more disabled you are, so EDSS 6, roughly speaking, is if you need a cane for walking. If you need a cane, your risk starts to go up 16-fold versus if you're less than that. And so not having MS is not necessarily a risk factor, but if you're starting to kind of accumulate disability and are wheelchair bound or things like this, that really appears to increase your risk. When they looked at the effect of drugs in this study, they noticed that there were differences between drug, but that's most of everybody who was on drug did better than people who were not on drug. Why might that be? Well, most people who are not on drug are older, and we know that older age is an issue. So this is looking at each factor individually. We can combine these, and we can see that if we combine this, you look into those patients that are older, they're probably going to have some extra disability. And so the age effect kind of comes down a little bit. Being a man gets washed out a little bit by probably a little bit of the fact that men have worse disability from MS. It's increased, but again, statistically not necessarily increased. Obesity just barely kind of statistically coming up, and it increases at maybe 3-fold. Having heart disease, not quite statistically there, but getting close. And disability, maybe not up to 16-fold higher, but still at 6-fold higher is a pretty big increase. And when they looked at all these things combined, which is what this analysis is doing, the effect of the drugs showed that there was no effect on severity. A similar study done out of Italy was a little bit different as far as what they found. And they found in this case that age still had an effect, that being a man, in this case, they looked at it the other way, being a woman provided some protection. It provided about a 33% chance of protection. Statistically, we would say it probably is close to meeting importance for it. Progressive increased it 2-fold. They looked at steroid use before the onset of symptoms by a month, and they saw an increase of 6-fold. And this will be interesting because one of the treatments for COVID is steroids. So let's keep that in mind a little bit, and we can talk a little bit more about it. When they looked at the MS drugs, the only one that really kind of jumped out was ocrelizumab or rituximab, the B-cell therapies. And this was about a 2.5-fold increased risk. So you had some studies saying yes, some studies saying no. They did a much larger study. Each of those studies had a few hundred patients. This combined data sets from them, the United States, and others. And now we're starting to look at 1,500 patients. So a much larger data set. And what does it show? Being women decreases your odds by about 40% of having bad COVID as you get older into that age over 70, almost a 3-fold increased risk. If you had progressive, almost a 2-fold increased risk. And that disability of needing a cane or higher, increasing your risk by about 6-fold. So very similar numbers to that Italian group. When we look at treatments with B-cell therapies, we can see for different types of outcomes. So chances of getting hospitalized go up about 50%. Chances of getting into the ICU 2.5-fold or an 150% increase. Needing a ventilator, 3-fold higher. Curiously, death was not part of what we saw that increased the risk of bad outcomes. So what does that mean? Is it protective? We will see. And part of the protection could be because when we think about the disease, there's the viral response. Things that affect the immune system might let the virus replicate faster. But in our response to it, sometimes our immune system gets a little bit too carried away. And if we can control that immune response, which some of these medicines may do, we may actually see some benefit. And so having COVID is a little bit too much. You have to talk about what stage you're in of the disease, and then whether some of the drugs might be beneficial or maybe harmful. And we'll see this again with steroids as we talk a little bit about later. This is another study that showed that, again, ocrelizumab in this case was a 4.2-fold higher increased risk. Most other medicines did not have an effect. Tisabri maybe having a 2-fold increase. This is the only study that saw this. I'm not going to put too much emphasis on this. But again, the one that seems to really stand out is ocrelizumab. So question number one about vaccines would be is, was the MS increase my risk? And it appears that it doesn't. The second one that comes up a lot is, does being on this drug or that drug increase my risk? Being on ocrelizumab appears that it does so, about a 4-fold increase, 3-fold increase. We got to remember and put in context, men have a 2-fold increased risk of having that. Being 10 years older has a 2 to 3-fold higher risk associated with it. And so the people that really have higher risk are those with multiple comorbidities, those that are older. So being on drug is only part of the equation. Same thing with age and other things. When we look at the effect of drug on other types of infections, this is pre-COVID data, we can see that rituximab is associated with infections that require hospitalization. More patients required hospitalization than patients on other drugs versus people who did not have MS or were not on drugs. We looked at this in a lot more detail at our center with New York University group led by Dr. Keister, and we can see again a lot of the same things. So what leads to an increased risk of infection, not necessarily again COVID, but just any bad infection? And the ones that really stand out are being male, 2-fold higher, disability. We can see almost a 8-fold higher increased risk if you're wheelchair bound. If you're cane, almost a 2-fold increase. And so these numbers are very similar to what we're seeing from COVID. And again, it just shows that COVID is another upper respiratory infection, of which we've had a lot of upper respiratory infections. So these same kind of risks that we've seen in the past are the risks that we're still seeing. B-cell therapies are thought to increase the risk of bad infections because they decrease the levels of antibodies. What we can see is that in this case, this is a report of 2 patients who survived COVID, and they have a genetic mutation where they don't make any antibodies. And these patients were able to recover COVID. So even though B cells are important and we can see an increased risk of infections, there's other parts of the immune system that help us fight those infections. So if you're young and can clear secretions well, you're not going to swallow, spit very well and end up in your lungs and end up with pneumonias and things like that. Other mechanisms will help you clear the virus and do well. So it's part again of that equation. So let's talk a little bit about vaccinations now. Now that we understand sort of all the risk factors that kind of go into COVID and people treated with the B-cell therapies, vaccinations is important, that it's a critical component of MS care. And the reason for that is that we tend to see, as MS progresses, a higher level of disability. As disability goes up, we tend to get more infections. We can't clear the infections as well. We don't empty our bladders as well. We don't cough up secretions as well because we have lung weakness. If we have skin breakdown, all those kinds of things increase our chances of infections. And if you have infections, your level of disability goes up. So let's talk a little bit about the different types of vaccines. This is the classic characteristics of vaccines that we've always talked about: the inactivated virus, long list of vaccines that we can see in that group. subunit or toxoid vaccines. These are they put a protein with something that lets you kind of react to that protein, this toxoid type stuff. And again, lots of examples of this. We can see that there's a group of lab attenuated that take the virus, grow up a lot of it, and they weaken it. The difficulty with this is that they have the potential to become infectious or virulent. These are the ones that we really try and avoid. And there's not a lot of these out there now. We don't have the TB vaccine. Yellow fever is uncommonly used. This one is mostly used in kids. The varicella zoster is the new version of this is not live attenuated, so we don't use this one very much. So there's not a lot of vaccines that we need to worry about in RMS patients. The flu vaccine falls under the inactivated ones. And now we're starting to talk about two vaccines that are completely different from anything that we've had. Vector and those RNA vaccines, which sometimes there's also DNA vaccines of which there's no examples. So let's look at some of these new ones. We can see that you can provide the gene that you want to make a protein of. So in this case, it's part of the spike. So if you have the virus and it looks like this is the part that binds to your cell and then can enter that cell and cause infection. So you can put the protein, the RNA that leads to having you make protein for you that recognize that. And the reason for doing the spike one is because that's where your antibody can kind of see and respond to these proteins. If you find a protein of something inside, the immune system isn't going to see it because it's protected by all this other stuff. So you'll see that a lot of these vaccines have been developed against the spike proteins of the virus. And you'll see that there's different ways to package it. You can put it in some lipid, some fats. This allows it to kind of get into the cells. And we'll talk a little bit about the difference between the Pfizer and the Moderna virus. Some of these lipids are a little bit different. The Pfizer one requires lower temperatures for storage and things like this. And that just has to do, again, with how it's packaged. So the Pfizer and the Moderna vaccine are of this type, both RNAs. The other one that we might hear a little bit more about is the AstraZeneca or the Oxford. That's this next one to come out, not available yet in the US, approved in the UK. And that has a virus that makes you make that spike protein. This virus that packages it is a type of virus called an adenovirus, and that adenovirus cannot replicate. It can't multiply. So this affects one cell, that cell makes protein, and then it's done. There's no other vaccines available yet in these groups. So these are very different, very new. And so a lot of the questions that you will ask me is we don't know because we don't have experience about the long-term outcomes with these types of vaccines. Similar ones, are very new and not used very much. There's a lot of guidelines around who should get vaccinated and things like this. How should we look at it? So some general concepts. We should ask about vaccination status before we start a disease-modifying therapy. If we can start, like say your MS isn't too bad and we can delay starting treatment, then maybe we should vaccinate you before. We don't think of MS as being a mild disease hardly ever, so we want to not delay the treatment. And so we want to start usually disease-modifying therapies fairly early. If you're having in the middle of a relapse, do we want to vaccinate you? Probably not, because if you're experiencing a relapse, this is a short period of time. We want you to recover from that just so you're kind of in a best position to kind of respond to that vaccine. We want to screen for certain infections. We can look for hepatitis, we can look for TB, the shingles virus, the varicella zoster virus. Why? Because these we can treat. So we can treat before we would immunosuppress you and let those vaccines maybe take over. For people who are on different disease-modifying therapies, we start to raise a lot of questions as to how good are the vaccines, how, do we need to switch you to other treatments if that's needed and things like this. And we'll get into that here in a little bit. So we need to consider sort of what treatments we're using. Do we need to switch treatments, those kinds of things before we go there. And a lot of that depends on how bad do we think that those disease-modifying therapies are affecting things. Well, we do have some information. We don't have it for COVID. Here's some data around a study called the Veloci study. This is looking at patients who received ocrelizumab and then received a number of different vaccines. And what you can see here on the left panel is pneumococcal vaccine. The pneumo vaccine contains many different types of bacteria strains that you can react to. And so you can see that for each one of these, how well people did who were not on Ocrevus and people that were on Ocrevus in blue. And you can see that overall for some of these, it made a huge difference. And for some of them, it really didn't decrease that risk much at all. We can look at the flu, and because sometimes the flus are viruses that we see every year, they looked at before and after the infection. So this is before and after for people that were on Ocrevus and before and after for people that were not on Ocrevus. And we can see that there's anywhere from a quarter or a third to about half of patients who would respond to most of these flu vaccines without vaccination because they maybe had the flu to something similar to it the year before. But that with vaccination, we can get a lot of to different strains, anywhere from 75 to 97%. Those people on Ocrevus roughly were anywhere from 15 to 20% less effective in making that response to that virus. Some of them were almost as good. So again, it just depends on the type of virus that's kind of going around that year, how well that vaccine is going to respond. So a lot of times it's like, oh, I still got sick even though I got the flu vaccine. Well, again, most years there's 3 or 4 different strains that really kind of spread through that can lead to these issues. We have to understand that besides sort of drug, that there's other factors. So we already talked about older people having more risk of bad outcomes. Part of it is understanding that people with who are older don't respond to vaccines as well. The vaccines tend to be tested in people who are younger, and we can see that, for example, to the flu vaccine, people that were older did not respond as well. We also see that not just with the flu vaccine, but also to the pneumococcal vaccine that we described before, hepatitis B vaccine. These antibodies don't last as long, so not only do fewer people respond, but they respond a little bit shorter than that. So there are some strategies that we can do that we can either do more boosters or change the vaccine some. So what are some of those things? Well, for the influenza virus in older populations, we tend to use higher doses. So almost a 4-fold stronger vaccine in for older patients. We can change the stuff. The adjuvant is kind of what triggers the immune system. We can use stronger adjuvants. This has been used, for example, recently with herpes zoster, the shingles vaccine, that allowed us to use the dead vaccine and actually made the vaccine much more effective. And so there's different strategies we can use, boosters and things like this, to really allow us to create an immune response in some people that may not have reacted. We can also see, for example, in this study, that people on rituximab may not have responded, for example, to the first 2 doses of vaccine. But here we can see that with the 3rd and the 4th doses, that their antibody levels get close to what we would see in patients who were not on drug. This was actually a study on rituximab in diabetic patients, so nothing to do with MS, but to kind of suggest at least that there's strategies for us to try and immunize almost everybody. And again, these studies have not been done with COVID, so more to that to come. This was against a virus that really doesn't infect humans called FECI 174. Of all random stuff, this was a virus that I studied as a high school student. And is used a lot for like high school science fair projects and things like that. I personally did not respond well to the hepatitis B vaccine. So I had received, when I started medical school, the vaccine series for hepatitis B. Now kids are getting the hepatitis B vaccine. It's usually 3 shots. This is the standard dose. And then you look for antibodies 12 months later. And I did not do this. I did not make antibodies to it. So they said, I went to residency and they said, well, you don't have the antibodies, so you got to go through this whole process again. So I went through the whole process again, still did not make antibodies again. So what worked for me was to do double shots. So every time I went in, I got double shots. In this case, they did an extra shot at month 2, but it's a way to kind of increase it. And every time these patients went in, they got actually double dose. So not only they get twice as much medicine, but an extra shot. This was in liver failure patients, alcoholics with liver disease, without that liver disease. And we can see that more people with this high dose responded than people that did not. So again, these are strategies that we can use, and we have to evaluate if we have patients who don't respond to COVID very well. So what are some of the vaccines that are coming out? We can see that, are they safe? Are they not? What kind of type of vaccines are there? So as of December, there was a ton of different vaccines being evaluated. The main leading ones we will see do not include the live attenuated. There's only 3 of these. None of these 3 were being involved in clinical trials yet. None of them are in the near horizon. All the ones that are kind of leading the pack are of the dead type vaccines that should be safe with any of our medicines. So what's leading the pack? So the Pfizer vaccine, 2 doses, 3 weeks apart, 95% efficacy. The Moderna vaccine, which actually got studied at UCH here on the main campus, 2 shots, 4 weeks apart, a little bit more stable, a little bit easier to ship, 94.5%. So very similar in efficacy between these 2 types of vaccines. The Moderna, the Oxford vaccine, kind of developed jointly. These are 4 weeks apart, not approved in the US yet, but approved in the UK. Is 70% effective overall from the study. People who got a half dose by mistake with their first dose actually got up to 90% efficacy. So whether that was just kind of random because it was a small subset of patients or not, we don't know. And some of that's why there may be a little bit of delay in trying to sort out whether this vaccine will or when it gets approved in the United States. There's a lot of other options. These single doses haven't come to fruition yet, and I've not heard of any other results. The Russian vaccine that's been being used in Russia, that they developed their own, is 92% effective. We're starting to kind of hear a little bit of data of ones from China, not listed here, and some of these other types of vaccines. And again, some of this will be more to come. So I think with this, the important point is to realize that there's different vaccines, that most of them include 2 shots, anywhere from 2 to 4 weeks apart, not all of them. But just kind of understanding that when you're scheduling these, you're going to schedule 2 appointments so that you can get your second shot. One of the impressive parts about this vaccine is that it was developed really, really fast. The prior record holder for development of a vaccine was 4 years for the measles vaccine. And one of the ways that this was improved as far as being able to develop it really fast is that usually the trial is done kind of in sequence. You do a phase 1 study, then you go to the phase 2, then you go to the phase 3. Here they did them all together, and they tended to overlap them. As soon as it was kind of good enough, they started building the manufacturing facilities right away. And so this allowed them to kind of really expedite how fast things kind of moved up. And so this is that warp speed type development program that really helped expedite this and really got us a vaccine with 9 months, pretty much to the day that UCH had its first case. We were getting our first doses of vaccine. So that's really impressive compared to the 4 years again for the measles. So who is getting expedited? How is it getting rolled out? Where are we at? I'm going to bring you to the last point. This is most likely to change, and we just need to kind of be aware that this is changing all the time. So it's kind of divided globally into 3 phases, 1, 2, and 3. The first phase, this is kind of where we're at, kind of divided into 1A, 1B. We think of 1A as sort of the emergency room, ICU, docs, people who are definitely getting exposed on a day in, day out to the virus. Some of this stuff is mostly pretty much done. It's expected that the 1A phase will be done in Colorado probably by the end of next week. 1B involves some of us docs, for example, that aren't necessarily seeing COVID positive patients, nurses, home health providers, PTs, those kind of healthcare workers, frontline type workers, firefighters, police, people working in nursing homes, correctional workers, and those kinds of things. Where we're at now is kind of above this dashed line where we're starting to kind of get people over the age of 70. This really got updated on December 30th. So there's still a lot of talk of what this kind of looks like. If we think about most of the healthcare frontline workers, we're talking maybe 124,000 people in the state of Colorado, over 500,000 people in the state of Colorado who are over the age of 70. So this added a big group to 1B. So these transitions between 1 and 2 are getting shifted a little bit because we might move people that were in one group to another group and things like this. But I think this is exactly the right process. Of all the risk factors that I think we've shown, people over the age of 70 as a risk factor is definitely the highest risk factor out there. And I totally applaud them for making that decision to kind of go by age for some of these, for the next group of people. We're going to then start to see a lot of educators, grocery store workers, and other people that have sort of essential jobs kind of get involved in 1B. So I expect that some of this, as it gets defined, will be explored more and more. All right, so let's look at group 2. Group 2, you will notice, doesn't include MS as a comorbidity. What you do see is immunocompromised, immunosuppressed. And the challenge with us at this point is that we don't have any more information than you do as to what this means. Not everybody who is immunosuppressed to the same level. Some people are immunosuppressed with really high dose, really bad, cancer type drugs that completely wipe out your immune system, and some people to a much lesser extent. And so how immunosuppressed, how immunocompromised do you need to be in order to get vaccinated? These are the things that we're still waiting to kind of understand as well. And then we'll start, and this includes patients over the age of 65. My guess that we will see is that we'll start to kind of prioritize this, and we'll end up with a group 2A, 2B, 2C. If you have 2 or 3 criteria, if you're one criterion over the age of 65, these kinds of things that we will start to kind of be able to start vaccinating those patients. So if we start to kind of look at winter, spring, summer, again, this just depends on sort of how many people we start to move from one group to the other and things like this to really kind of get a sense for that. I do think that with as much in the way of delays that we've had, that we should be able to get almost everybody vaccinated who wants a vaccine by the summer, and kind of getting a sense of hopefully returning to normal maybe by the fall. So where are we at in the state of Colorado? So we have access to the Pfizer vaccine and to the Moderna vaccine. The Pfizer one was approved a little bit faster than Moderna was by basically 1 week. So the early vaccines that came into the state were the Pfizer. Then you started to kind of see sort of an onslaught of Moderna vaccine. And as we start to kind of get more batches of the Pfizer, now we're starting to kind of see a mix of these. We've had about 120,000 people vaccinated in the state of Colorado. That's about 2% of Colorado, which if you look at most other states, this is really a pretty good model. UC Health has provided over half of these vaccines from what I understand. I just got my second dose today, and I just heard that at the clinic here on the main campus that they're scheduled to vaccinate more than 2,100 patients today. So this is getting ramped up really pretty fast. The number of clinics is going up. The number of other health systems providing vaccines is going up. So I have a feeling this is getting kind of ramped up pretty good. But one of the concerns that has been mentioned is that there was a lot of vaccine kind of given out early, and unfortunately, not a lot of it was being used. So where are we at as a U.S. population? This comes from the Times news magazine, and we can see that only 1.3 in the U.S. of the U.S. population has been vaccinated. That's particularly bad considering that about 6.1% of the population could have had vaccine because that was how much vaccine was already shipped. So we're starting to see that these aren't great numbers as far as a lot of the vaccine being used to kind of get out. Again, in Colorado, we're doing pretty good. You can see that some states are getting more vaccines than other states. But as far as kind of what percent of a state is getting vaccinated, we can see that Colorado is actually doing really pretty well. But only about 22% of the doses were used so far. So I think this is going to get sped up a lot better. But you can see that certain states just haven't gotten their act together. So at least we're kind of trudging along pretty well. So what's the process like? I told you I got my second vaccine today. So for people who are at UC Health, the process currently is starting with a My Health Connection. This is how all notifications happen. All our patients should have received by now a notification that that they're on their list, basically. Hey, we're aware that you're out there and that kind of stuff. When you get an invitation, it'll come out the same way. Then you're going to schedule not only the first vaccine appointment, but you're going to schedule the second one. It may prompt you about payment. The vaccine is free, so really just answer it so you can kind of move on, but that's about it. My registration for the second one today, those questions kind of came off. Again, they're still learning and the process is still getting better. So just kind of recognizing that. I showed up in a full dress shirt, so just show up to your appointment wearing comfortable clothes for easy access, because I ended up having to kind of strip down in front of a big group just to get my shot. And so just being aware that if you can wear sort of sleeveless, short sleeves, that kind of stuff, things that you can kind of move up easier, it's a little bit better. The shot's still a shot. The technology has not gotten better. It hurts a little bit, but it really goes pretty fast. Not that big of a deal. One thing to plan ahead for is that they will ask you to wait there for about 15 minutes to look for allergy reactions. Think about anaphylaxis. These are the reactions that you're hearing a little bit about in the news. Not a lot of cases. As of last week, I'd heard about 5 throughout the United States. These are patients who are developing low blood pressure, kind of quick, rapid pulse. Think about peanut allergies, bee sting allergies, that kind of stuff as far as kind of what the reactions are looking like. These are all happen within 15 minutes. These are patients that if it does happen, what they're doing is giving epi, kind of like with the EpiPen should, for those people who have sensitivities to bee stings, for example. If you had an anaphylactic reaction to another vaccine, then they're going to make you wait 30 minutes. They're saying you're not supposed to get this vaccine if you've reacted to similar vaccines in the past. Well, we've not had similar vaccines in the past, so I'm not sure how you would know that. But I guess they just like stating the obvious. And then you show up for your second appointment, kind of the same thing. You made your appointment and you got to kind of repeat all those kind of steps. So that's the process. I got my first shot on the right arm. I sleep on my right side. I would not recommend that. It was a little bit sore for a couple of days. And so just being aware of that. So I think there's a lot of questions that we're getting in clinic. And some of these we know the answers to, and some we don't. And unfortunately, that's probably the biggest category. So I'll go through these a little bit briefly, and then we have a little bit of a Q&A type time. The vaccination in MS patients on immunosuppression. So I have had MS patients be looked at in the studies. There were patients that were not on immunosuppressive therapy. So some of the older patients were included in the vaccine trial. So we have a little bit of data in older patients. They do seem to mount an immune response, thankfully. This is something that we're starting to kind of look at a little bit. We've had about 15 providers, either docs or nurses who have MS, who are mostly on B-cell therapies, now getting their vaccines. One I know got their second dose earlier in the week. And a lot of them are starting to kind of get them today, tomorrow, and over the weekend, early next week, and that kind of thing. So far, so good. Not had any bad reactions or anything else like this. We're starting to look at some antibody responses and things like these in some of these patients. We're very grateful for everybody who's volunteered to kind of get some blood drawn to do this. We don't expect that there'd be any interaction with any of the MS drugs. The main thing is whether you're going to respond to the vaccine, and that is, again, the things that we don't know. It appears that a lot of people still mount an immune response, as we talked about with B cell therapies, but we don't know for this type of vaccine. There's a lot of questions about, should I time my vaccine? Should I wait till the end of the 6-month cycles for those patients on B cell therapies? My answer is that it's better to get it than not to get it. We don't know that it really matters. Most patients don't have B cells throughout the entire 6 months. So there's not probably much different between the end versus the beginning of the 6 months that would result in this. So my personal view is you get the vaccine, but I can tell you at a lot of centers, they are trying to time it and kind of recommending that people wait to the end of their cycles to get it. If you've had COVID, should you get vaccinated? No idea. Most of the antibody testing out there does not look to see whether you're responding. It looks at the nuclear protein, not to the protein that you're making with the vaccine. So you won't know if you're responding to it. There are some places that do look at responses to the spike protein, but it's complicated. And so therefore, it's a little bit hard to recommend getting sort of antibody tested, and if that's the case, then whether you should continue on to get the COVID vaccine or not. So right now, the recommendation is to go ahead and get the COVID vaccine. People who were part of that Moderna trial here in Colorado are going through and getting the COVID vaccine. How long does the COVID vaccine last? Again, not sure. What we do know is that when you get exposed to the coronaviruses, of which COVID is one, usually the antibody in the immune response appears to only last from anywhere from months to a couple years. And so this may be sort of an annual vaccine that we end up having to get. If you think about it, there's only 4 real types of common colds out there of the coronaviruses. That was before this COVID types of viruses came out within the coronaviruses. And the common cold is caused by the coronaviruses. And so for us to get them multiple times, between only 4 times, means that we could keep getting the same kind of cold virus over and over and over every few years as our immunity would kind of wane out. So I suspect that we're going to need to do that. Does it matter which vaccine do I get? Well, right now there's 2 options. We'll probably get other options in the next few months. The Pfizer and Moderna, they appear very similar. The 95 versus 94.5% difference in efficacy, again, not any difference that I'm going to right away about. They're both RNA vaccines. I would just get whatever you can get and kind of go from there. As far as pregnancy and vaccination, it's not been tested. I think the general recommendation is going to be not to get vaccinated if you're pregnant. What if you're breastfeeding? You know, my thought on this is that you could probably pump and dump for a few days and that it would be fine. I don't expect that to be an issue. The vaccine has not been tested in kids, but again, it looks really safe. The Pfizer goes down to age 16, then Moderna down to age 18. So right now there's no vaccine for kids, which is maybe why you're not hearing about vaccinating kids at all yet. I think more studies are to come on that. If we look at treatment, so this is very different from the vaccine. I just wanted to touch base on this because we had a fair number of questions around this. And one of the things I want to highlight with this is that there's very many differences between when these treatments should be used. So convalescent plasma was one of the very first things. This is antibodies, plasma, which contains antibodies from people who have recovered from coronavirus and giving it to people who are now sick with the idea that it would help protect them. The data is a little bit kind of up in the air. It appears to be a little bit helpful, not great data. They've developed monoclonal antibodies, so lab antibodies to COVID, with the idea of kind of being able not to have to get those antibodies from other people, but just to grab them from the lab. It only appears to be helpful if you present within 10 days of symptoms. And because of the limitations of being able to get these antibodies and these treatments, it's really reserved for people who are at high risk for those bad outcomes. Again, go back to the earlier part of the talk, you can see what those high risk type factors are. So somebody coming in who's 70 or 80, would be sort of a good ideal candidate to get some of those monoclonal antibodies. There's a couple of different versions of these made by Eli Lilly and Regeneron. Dexamethasone is one. This is a type of steroid. This is the one I was alluding to before. So again, when do you use it? We saw this higher risk before kind of COVID, and yet it's now being recommended for people with COVID. So why would that be? What's going on? Well, if we look at mortality, so higher is worse, more mortality. If we look at people who do not need oxygen, dexamethasone appears to increase the chances that you would do poorly. Not statistically significant from our end. We like to see p-values less than 0.05, but at least trending in the wrong direction, that dexamethasone is actually going to hurt you as opposed to help you. If you're on a ventilator, however, the mortality by usual care was about 40%. There was a reduction by 10% mortality in this group of patients by dexamethasone, a reduction of, in this case, 35% that we saw. So again, not everybody with COVID is in the same place on that spectrum of the disease. If your runaway immune system is bad, steroids can be helpful. You probably don't want to treat the viral infection itself and suppress your immune system with steroids. So important to kind of recognize that. Remdesivir, similarly, is best used for patients that are hospitalized. And then we get a lot of questions around hydroxychloroquine, chloroquine, ivermectin, vitamin C, D. Okay, maybe not leeches, but we get a lot of questions on treatments that to me make no sense. We've had a lot of patients on hydroxychloroquine because it's still used a lot in the rheumatologic field. A lot of patients with rheumatoid arthritis and things like this on this medicine, and guess what? They still get COVID. Trump supposedly was still taking hydroxychloroquine, still got COVID on this medicine. As a preventative, it does not even appear to help. I'm not sure how it's going to help if you're going to take it once you're sick. Chloroquine's an older version of that. These have some heart issues associated with them, so the mortality rate was actually higher on these medicines than if you didn't take them. Ivermectin is an antiparasitic. This idea that this is an antiviral, I don't understand where this is coming from. This medicine is used to treat tapeworms, pinworms, that kind of stuff. So if you have a pinworm, a tapeworm, yes, take your ivermectin. I don't know how it's going to help with any viral infection. Vitamin C, vitamin D, again, there's a lot of things that we thought were helpful at one point that when we actually do the studies, bleeding has not been helpful at all for pretty much many conditions. So when we start to look at considerations for COVID, we have to understand what the patient is. Are they at high risk? Are they at low risk? What is the vaccine characteristics? We definitely don't want to do lab attenuated vaccines. Do we need boosters? What are the strategies for people who don't respond? How do we measure non-response? Some of these things, this part, we don't understand very well. We have to understand the disease characteristics. An MS patient who is in their 60s or 70s is very different from an MS patient who's in their 20s. And so we need to understand that, and then probably put those patients who are older and have a lot of other comorbidities, higher in the list. We probably don't need patients who are on some of the oral MS therapies because those don't appear to be an increased risk for developing disease. And then we have to understand those disease characteristics. So again, it's putting all these things together, not just any one aspect of it, that becomes important in putting people in understanding this. So to kind of conclude a little bit, COVID-19 cases are stable in the world, decreasing in Colorado. Social separation is effective, wear your mask. MS patients on B-cell therapies appear to be at an increased risk. Get vaccinated once it's available. Sign up for My Health Connection. That's how we will be notifying our patients. Talk to your primary care provider if you're not part of our patients. Talk to your other providers to kind of see how they're going to notify you if you're out of state, see what your state's doing, because every state's doing something a little bit differently. And then I think it's important to kind of just understand that it's important to take care of yourself. You can't get cooped up at home. You have to exercise, you have to eat right, you have to be well to do well. And so with that, let's look at some questions. Kelsey, if there's anything we didn't cover, or things coming in on the chat, happy to answer any other questions.
Excellent. Thank you, Dr. Alvarez. I just want to reiterate a couple of things before we get into the Q&A. We are unable to give specific medical advice out during the webinar, so we are going to be answering general questions. If you have questions relating to your specific treatment plan or risk factors, please discuss these with your neurologist and your primary care physician. I also encourage you to check out our COVID-19 education page at mscenter.org. We've been producing and collecting many resources about COVID and MS and how to keep yourself physically and mentally healthy during this time. And I'd also like to reiterate what we know about the vaccine distribution process for Colorado. It is moving more slowly than originally anticipated. We are currently in phase 1A and 1B of the state's vaccine distribution plan, which includes healthcare workers, essential workers, and individuals over the age of 70. Dr. Alvarez has outlined the phase 1 categories in more detail. The majority of phase 1 recipients will receive the vaccine through their employer or a local public health agency. If you fall into the phase 1 category and have questions about where you can receive the vaccine, we recommend that you call your primary care physician, your county's health department, or Colorado's information hotline at 1-877-462-2911. The COVID education page at mscenter.org also has a couple of links with additional information about how healthcare systems are distributing to phase 1 eligible people in our article about vaccines. After phases 1A and 1B are complete, phases 2 and 3 will begin. The Colorado Department of Public Health and Environment states that they will soon be providing more information about these phases. The Rocky Mountain MS Center will continue to bring you the most up-to-date information and guidance about Colorado's vaccination plan and how to best receive your vaccine. And now we will move into the Q&A portion. I will be grouping similar questions together because we have had a large volume, and many of the questions that were submitted at registration have been answered during the presentation, but I do want to thank you guys for submitting those ahead of time. So for our questions, I know you went into some detail about the effect of the B-cell therapies on vaccine effectiveness. Can you just touch on whether it's a concern with some of the other medications like Tysabri, Aubagio, Gilenya?
Yeah, at this point, we're not seeing that a lot of the other medicines. There was the one report that showed maybe a little bit of an increased risk for patients on Tysabri or natalizumab. And so I think it's one of those that at this point, we still need to understand, how much risk they are actually associated with it. I suspect that some of that might be just we didn't see a difference because there's not that many patients on some of these drugs compared to other drugs. And the other part that we don't understand too much is some of the other drugs may be associated with the vaccine not working quite as well. Gilenya maybe has a little bit of that, kind of that group of drugs, the S1P type drugs, and things like that. But again, most of these decrease in effects are not big enough for us to say don't get vaccinated.
And then do you have any thoughts to add on people who have MS but are not on a DMT, if there are any additional considerations they should think about?
We're not seeing any concerns in that regard. I think the vast majority of our patients who are not on disease-modifying therapy may be because they're older and have higher levels of disability. So it would be those components of it that would make it more concerning for us than the fact that they're not on disease-modifying therapy.
And we had a lot of questions in our registration about vaccine safety. Do we know some of the side effects? I know you mentioned there's very limited data for folks with MS and the vaccines, but just kind of generally speaking to how we think that the vaccine won't interfere with MS medications.
Yeah, so because people on kind of the MS type drugs were not included in the study, all I can tell you is that we have absolutely no information on that, except for the personal information that I presented. What we can get a sense of is that the patients so far that we've had have done really pretty well. Whether or not they're protected, I think remains kind of a lot of the big question marks out there. These are kind of the big parts about it. We wish we had a little bit more control as to who would get vaccinated and how to get move people up and down the lists and those kinds of things. At this point, this is strictly coming in through the federal government to the public health entities who are contracting out with the health systems and kind of dictating who gets it. And it's a random process. So your number kind of, if you meet within a group until there's enough vaccine for that group to get vaccinated, it is coming down to a lottery system, and it's kind of first come, first serve. So my biggest piece of advice for that is kind of registering for the My Health Connection app for our patients, reaching out to your providers to know where and how to get those vaccines. I suspect there'll be eventually, once we start getting more vaccine and things like this, the vaccine will be probably available at Walgreens and CVS and all the other places. And, you'll be able to kind of just pop in, make an appointment and get, an appointment made to get vaccinated.
You mentioned that the standard antibody test doesn't measure your reaction to the vaccine. Did I understand that correctly? That we had a question wondering if people should take an antibody test after their vaccines.
Yeah, so this was a learning point for me just a few days ago. The antibody test at most places, some places do look at antibodies look at antibodies to the spike protein, to the outside protein, but most of the tests out there are looking for antibodies to the nuclear proteins, to those inside proteins. And so if you get vaccinated, you're only going to make antibody to the proteins on the spikes. And so you won't see any antibodies being formed to those nuclear ones. So depending on what test is being done, you may not be able to see whether you're responding to the vaccine or not. I suspect that we will get more and more access to spike protein type antibody testing. We're starting to kind of do some of this through a research lab on campus for these patients to kind of understand this process a little bit better. But for example, I saw that like Poudre Valley maybe has that spike protein. Again, whether it's the right part of the spike protein or not is the part that I don't know. But it's at least not to the nuclear capsid protein and things like that. So this is the part that on the testing side, we'll have to know. I can tell you, we even got caveats when we were doing this on the research side, when they were doing the nuclear capsid, in the sense that they couldn't guarantee that just because you had antibodies that you were protected. They wouldn't kind of say it's a positive or a negative test, that you were had those antibodies or not. You just kind of get a number and a score, kind of, in a sense. So I think this is the part of stuff now that we are really starting to kind of needing to understand a little bit better, and kind of seeing, how well people are responding to things.
We had a couple of questions come in concerning the clinic tracking folks who have gotten the vaccination. Will you guys be tracking? Do you know of clinical studies following folks with MS who get the vaccination? And then if somebody has the vaccination, should they alert the office to let them know so they can be included in those studies?
We don't have studies where the efforts I'm leading a little bit are to just kind of get a handful of patients so that we can at least get some information on like 10 or 15 patients. We would like to try and expand that. It's just trying to be able to get the manpower to kind of be able to do some of that testing. I think we'll get a handle for it, a little bit of an understanding. There's people that are doing a lot more of this, but because Colorado and especially at UC Health, we kind of had a bit of a head start. We had an early start. I mean, we had a lot of providers get vaccinated right away in that first week. I think we should be able to get data pretty fast. And so that's why we're doing a little bit of a pilot. We'll let the professionals kind of do it a little bit more kind of with time. And so we do appreciate people communicating with us. It's a little bit of a challenge sometimes when we have somewhere in the order of probably 4,000 patients, trying to keep track of to who got vaccinated, who didn't, and those kinds of things. If you get vaccinated through us, we'll be able to see that. But otherwise, it's a little bit of a logistical nightmare. We are unfortunately a little bit understaffed in the clinic at this point. As you can imagine, vaccinating 2,000 plus people in a day through any one of our clinics, and probably around 5,000 people as a system in a day, requires a lot of manpower. And so a lot of our staff is being deployed to those vaccine clinics, are getting redeployed to the inpatient units to help out with those patients that are in the hospital. And so we don't necessarily have the capacity to kind of reach out and keep track of things as well as we would like to. I think some of those things are starting to improve because the numbers are starting to kind of look better. I think we will be able to kind of start bringing our staff back into the clinic and try to keep up with things a little bit better. But these are the challenges that we are currently facing, kind of like the challenges that almost everybody else is facing with homeschooling and everything else like that. So we are tracking a few things. We are trying to learn things. But as much as I would love to say, yes, let us know, that the reality is that it'd be hard for us to kind of keep up with all those messages.
Is there any data on, is a half dose as effective as a full dose, or do you really need to make sure you get both of those doses?
This is a really controversial topic right now because certain countries like the UK are starting to kind of maybe think about doing a half dose. There's a little bit of data that a half dose maybe seems to be as good. Unfortunately, in the US, you're going to get the full dose because you can't split the doses. It's a little bit of a shame because I'm not sure if people remember these from the early days of the Pfizer, but the vials were meant to have 5 doses in them. And the reality is that there was like a Christmas bonus gift in many of them where they could give like 6.5 or 7 doses. The challenge is that with 6.5 messages, with those 6.5 doses, is that they couldn't save that half dose from this vial, a half dose from another vial, and combine it to give it to somebody else. And so like that would have to kind of get wasted. So that's kind of the challenges that are coming in the distribution line a little bit. So at this point, the half doses are, I would say, pretty much out. I would strongly recommend people to get the same vaccine. There's no mixing and matching, coming in and getting the Pfizer for the first dose and then Moderna for the second dose. That's just not what's happening, at least here. They're keeping really good track record of which one you got. Do you get a little vaccine card, your vaccine passport, if you want to think about it that way. And so we'll see where we kind of come out with as far as vaccine goes.
You mentioned briefly how this vaccine was able to be developed so quickly, is that they overlapped a couple of the phases. Can you just go into a little more detail that all of the safety and various clinical trial levels were followed, just overlapped rather than spread out?
Yeah, so all the right phases were completed. It was a lot of times when you're doing sort of a clinical trial, it takes some time to kind of analyze it. There was a particular emphasis on trying to kind of keep analyzing things as you were moving along. Usually a phase 3 is just a larger version of a phase 2. Well, if you're starting to do the phase 2 and that, starting to kind of look like people are doing okay, let's just start the phase 3 and start moving that one along. So all all the things that we need to are getting collected and getting evaluated. We have to remember that the drugs aren't really approved. They're kind of approved under this umbrella term of an emergency use approval. So it's not a full approval. That's a little bit why the federal government's so involved in the distribution of these vaccines, so that we can get, still learn about it. And I forgot to answer this question earlier. As far as studies, the one big place that's tracking it, and you'll get information when you get your vaccine, is through the CDC. There'll be a link for registering through the CDC to report any side effects that happen through the study. And so they're the ones kind of giving us information about the number of allergy responses that people are developing and things like that.
I know, again, you mentioned some of this in your presentation, that things like disability level matter, and folks who generally have progressive MS generally have a little more disability, but are there any other considerations on folks who are more relapsing, remitting versus progressive that they should be concerned about or would move them up in the vaccine schedule?
Yeah, again, the vaccine schedule, we don't have a lot of details. So as details come out, we will push for those things. These are sort of on the observation level. So if we could push them and it was just kind of the MS, we'll have to kind of go from there and see, how we can get people in. I suspect that most of these things will come down to kind of things that can be picked up on the electronic health care record a little bit easier. I think part of the reason for picking age as sort of the big risk factor to kind of go after, besides that it's a big risk factor, is that it's easy. The date of birth is very much involved with kind of the response that we're seeing. It's part of the record. As soon as you pull up your name, you see the date of birth, you can see how old they are, and then kind of send an invite to people that meet certain thresholds and things like that. Disability is a little bit harder to measure, although some of these cutoffs, you need a cane or other things like this, are the things that a lot of times we'll see prescriptions for canes or other things like that. So I suspect that some of those things will be a little bit harder to kind of see. I suspect that most of the people who have those advanced levels of disability will likely get caught up on other of the measures that are getting pick people up. In other words, they tend to be older patients. They tend to be, if really severe, they might be in nursing homes, those kinds of things. And so it's likely that many, that they'll start getting picked up on the tiers by 2 or 3 different factors.
We are completely over time, so I'm going to try to summarize what I think I've heard you say, and you can let me know if that's correct as we close out. For the distribution of the vaccines, MS is not listed on the list of things that would move you up by itself. We don't know at this point if things like the B-cell therapies would necessarily put you in an earlier category. However, as soon as we do know, the Rocky Mountain MS Center will gladly share that information with folks. But I'm hearing that we don't know for sure right now that will move you.
That's correct. And we're working on trying to get that information as much as we can. So through our department and through kind of our infrastructure, we actually have a little bit of a closer ear to the governor, because one of our neurologists actually sits on the public health board on the governor's public health board. So, this issue of like what constitutes immunosuppression, we've run it up the ladder in multiple different formats to try and understand that. I think it's one of those things that there's certain drugs that we know a little bit better than others as far as healthcare system overall. In other words, rituximab, for example, is much more widely used between cancer, rheumatoid arthritis, and things like this than maybe our more niched out Ocrevus. So, for example, when we got the initial list of immunosuppression back in March and April, rituximab was part of that list that was considered to be an immunosuppression type medicine and at higher risk, but Ocrevus, for example, wasn't. So trying to kind of understand, will Ocrevus make that list or not? So I'm sure it'll be part of that work that's happening, and they got really smart people working on these things. But right now, they're really focused on trying to get doses out to phase 1 and phase 2 people. And I think it's trying to kind of, in a sense, for as much as we may talk about comorbidities and other things like this, people who are working in the front lines are the people getting exposed to the virus, and some of the other people are having at least a little bit more of a chance to kind of be protected and not have to expose themselves as much. So getting vaccines to the higher risk aged, as well as people working at grocery stores and some of these essential workers and teachers, and trying to get kids back into school and things like this. I totally agree with that being kind of a priority. And so I bet you they're working on phase 2. I know they're working on the phase 2s and that kind of stuff. And it's just going to be trying to come up with the meat on the bones around sort of the sub-tiering that's likely to develop around group 2.
As far as how you can advocate for yourself, for UCH currently, they're probably using charts to decide who to reach out to, and UCH will reach out to you. You don't need to, there's not a list you can put yourself on.
Correct. Yeah, there's nothing that I cannot write a prescription for a vaccine. There's no order in it for me to kind of be able to write it. I've had healthcare providers who are maybe on private practice reach out and be like, hey, can I get my vaccine through you guys and that kind of stuff? And the answer is, unfortunately, I can't, even though they're part of the 1A group sometimes. It has to be through your health organization that's there and going through the State Department to try and get access to that. I suspect that some of this will open up with time, but as of now, that's not the case. I suspect that certain things like age will be something that you can show a driver's license again, and then that can get you qualified to kind of become in some of these earlier waves. I suspect as well that as we get into group 2, that some of the clinics may get access to vaccines individually, and we might be able to start handing out these doses. It's a little bit trickier than that because these vaccines are fairly unstable in the sense that they have to be kept at really cold temperatures and things like that. The Moderna is a little bit more stable. The AstraZeneca Oxford one is even more stable than that. But it's not like the flu vaccine that you can kind of keep in the Pyxis or the little machine that's in the clinic, and the doses can sit there for a month and just kind of pull out a dose as needed. These come in multi-packs. They got to be used usually within a few hours of kind of getting them out of the freezer and things like that. And so you really want to have a line of people kind of ready to go so you're not wasting those doses. And so, big clinics, if we can share them per the floor, those kinds of things may be the case. But I don't expect that to be the case for quite a while. And I suspect they'll be through kind of big kind of vaccine centers to kind of take advantage of every last drop of the vaccine that we can get.
Excellent. And then just kind of one final note to end on, generally speaking, take whichever of the vaccines you can get, and you're recommending the vaccine generally, very generally speaking.
Right. And talking to all of our providers are 100% in agreement to get the vaccine. We see it as safe in the sense that you can't get COVID from it, those kinds of things. I think the only group of people that we might sometimes have some hesitation around might be patients who have had a reaction to another virus that led to them having a Guillain-Barré type of a picture or a transverse myelitis. In other words, who had neurological complications from a vaccine in the past. in talking to different groups and things like this, the opinions there kind of vary widely. And so it is kind of difficult at this point to kind of say, oh, you for sure should get one. We're being a little bit more cautious in that group. The allergy response is very uncommon, those kinds of things as well too. So again, I think as we're noting, right, there's a lot of very good questions for which we don't have an answer to. And we got to consider the fact that this virus is barely a year old, 7 years and dog years maybe. But, that unfortunately, that's not a very long time. And it's been impressive that we have the vaccines developed. But a lot of the same questions that are just answering for other types of vaccines, we've not had the opportunity to test out. And so I suspect that in the next 3, 6, 12 months, we will continue to learn much more. I think the big question that remains in everybody's mind is, when will things get back to normal? Again, no clear answer on that, but I do suspect that the vaccination will speed up, that by the summer, I suspect things will start to kind of normalize out some. And hopefully by the fall, we'll have a sense of where we're at with things. Most of the people who want the vaccine will probably have a vaccine by then. There's discussions of at least 100 million doses of vaccine being available probably by May and June, which would be about a third of the population if you include that we can't vaccinate kids yet and things like this, and they do really well no matter what, that we can probably get vaccines to everybody who wants them, who's over the age of 18, by at least mid to late summer.
Awesome. Thank you so much for your time, Dr. Alvarez. Thank you everyone for your questions. Again, we will be archiving this webinar on mscenter.org and YouTube. And please make sure that you're signed up for our mailing list in order to receive notifications about additional programming. Thanks and stay safe.